So I think this symposium was so well designed because now the anesthetist will talk to us, who is actually the more appropriate person to learn from. Dr. Hajek is going to talk to us about platelet multimodal function monitoring. And I do remember we used to refer to the green sterile sheet between the surgeons, the anesthetists, as the blood-brain barrier. So we're now expecting the real brain to talk to us about coagulation. Thank you very much.
Thank you. Good afternoon, everybody. The talk is about platelets. Platelets are the very important part of normal hemostasis, not only primary hemostasis, but also in the face of propagation and amplification of entire coagulation procedure. The procedure is ongoing not only in vessels, but also in circuit. Common finding after bypass is thrombocytopenia, partly due to hemodilution, partly to blood loss. But there is also a significant platelet activation during the bypass. We have in clinical practice and very little option to mitigate the activation of platelets. One of these is limit or avoid to suction, and because the shed blood reinfused increases platelet activation and also platelet damage. And we have also some pharmacologic option to use antifibrinolytics that not only blockade fibrinolysis but preserve platelet activation through the PAR1 receptor. So that is empirically known that isolated platelet count above 50 giga per liter is usually not associated with serious bleeding, of course, in setting when patient is not on active antiplatelet medication. Bleeding is still issue for platelet. This is the one of classical model of bleeding prediction by Kerkuti. There's the odds ratio for thrombocytopenia was higher. Surgeon is disappointed that usually say give more platelets, but in many cases, even if patient is on antiplatelet medication, the transfusion of platelets doesn't solve the problem, especially on ticagrelor. Ticagrelor is now very popular in cardiologists. In Czech Republic, many emergency medical physician in the case of chest pain administer ticagrelor, and ticagrelor is reversible inhibitor, and if we take some platelet transfusion, it inhibits platelets too. Cardiologist is very happy. The more is the better, and for anesthesiologist is the hard place. Many years ago, we in an observational study using thrombelastography, such a global test, we detect the platelet dysfunction about 25% during cardiopulmonary bypass and 15% after the bypass. But classical thrombelastography cannot discriminate between thrombocytopenia or platelet dysfunction. One relatively new option to protect platelets is sequestration, using some new generation of cell saver with very gentle centrifugation of plasma. We can reach platelet-rich plasma, which can be retransfused after the surgery. There are some clinical data. One of the biggest study is from Texas Heart Institute with using this setting, and it show some reduction of transfusion and reduction of bleeding. This is the paper from a group of Cyril Serik from Toronto. They measure platelet function by aggregation stimulation by ADP in different autotransfusion devices and show good platelet function. Couple of weeks ago, the group from France presented the new data with using the platelet-rich plasma sequestration, but very satisfaction with clinical parameters. but they don't explain how to measure platelet function. The options of measure of platelet function are also aggregation or some monitoring of some receptor expression on the surface of the platelet. One option is optical aggregometry. Also, we can use impedance aggregometry. There exists some multiplate analyzer. It can be used as a point of core test. There are the stimulation of different receptors for different substances that induce the platelet aggregation. There are the calibration curves and normal ranges. We can also use the modification of tone elastography for TEG platelet mapping. The principle is very similar. There are some activators, some inhibitors, and we can measure percentage of maximum amplitude aggregation. This method is formerly was not user-friendly because very time-consuming. We need two analyzers. Today there exists the new analyzer with cartridge. Its examination is provided to 10 minutes. This is the chromatographic detection of CD receptors, flow cytometry, CD receptors, couple of receptors on the platelets that interacts with some inductors of aggregation. And the receptors are not only on platelets, but also on microparticles. Microparticles are small plasma membrane vesicles shed from different cells upon activation or apoptosis. And platelet-derivated microparticles constitute the majority of the pool of microparticles. They are a source of tissue factor and as negatively charged surface assemble the clotting factor complexes. So I show you our data with platelet monitoring. We use platelet-rich sequestration in elective cardiac surgery patient with estimated cardiopulmonary bypass duration above 2 hours. It must be patients with good initial hematocrit above 35% because we remove 800 milliliter of whole blood before the procedure to avoid the effect of surgical stimulation and bypass such. We measure the aggregometries parameters and TEG platelet mapping. It was not on MiECC, it was on standard cardiopulmonary bypass with prophylactic tranexamic acid dose. This is our transfusion protocol. Platelet-rich plasma was retransfused immediately after surgery, red blood cells, if necessary, on operating room or ICU. And we use our institutional transfusion algorithm using TEG. This is a group of 30 patients, no differences in demography, no differences in clinical adverse reaction. Parameters of cardiopulmonary bypass, of course, the same. No differences statistical significant in transfusion therapy, no in outcome, but the aggregation. Before PRP transfusion on the bypass, the aggregation for ADP and ristocetin is good, but for collagen and epinephrine is very decreased. This is the situation in the processed plasma. Only ristocetin activated aggregation, it works. And this is after the transfusion. This is the trend to normalize, but not to the baseline. We repeat this study with some other measurements. It's a small study, 10 patients for platelet-rich plasma sequestration, 10 for control. No differences in transfusion, no differences in parameter of thrombelastographic platelet mapping. We measure also optical aggregometry. You can see the same results as above, the partial protection for ristocetin and ADP. Flow cytometry parameters, there are some activation of receptors in the separated plasma, but at the end of the surgery, there was no differences. And interesting, very huge activation on the microparticles. So, I must conclude this is difficult to measure platelet function in vivo. Nor aggregometry nor thrombelastography is not primarily developed for the measure of platelet function. It was the forced aggregation. It is good for the test of antiplatelet therapy, not for situation in vivo. And if we take the platelet-rich plasma sequestration as a part of blood conservation therapy is in question. We have clinical data that are good, but we have in doubt about the real function of transfused platelets. Thank you.
Thank you very much, Dr. Hajek. This is impressive research that you showed us. Just a very quick question then. So your bottom line of your intraoperative management is really not ready yet. It's a matter of research, do you think? Or what do you do in your day-to-day practice?
In the we don't use it in the daily practice. We use only red blood cell sequestration, no platelets.
Thank you very much.